Hi everybody, welcome back to UWorld's Next Gen NCLEX review session. My name is Jackie and I'm a nurse here at UWorld. We're so glad to have you guys with us today. We are covering one of the most requested topics, so we're going to be covering ECGs today. We have about 8 questions we're going to go over. Each of them include a different ECG strip for us to interpret. We're going to focus on the correct answers only so we can really talk about how to digest these strips and make sure we understand what's going on with all of them. But again, we're so glad to have y'all here. We encourage you guys to use the chat. We have Nurse Samantha moderating for us today. So be sure and say hello to her, ask questions along the way, and be sure and follow us on your favorite channel. We'll have this available on demand when we're done. So with that being said, let's go ahead and jump in and get started. All right, question 1. The nurse is caring for a client who is experiencing the cardiac rhythm in the ECG strip shown below. The nurse should recognize that the client is experiencing option 1, atrial fibrillation, option 2, ventricular fibrillation, option 3, ventricular tachycardia, option 4, sinus bradycardia. All right, 30 seconds on the clock. Drop those answers in the chat. Again, if you guys are just logging on, just getting into the live, we are covering ECG strips today. So one of the most requested topics, something I know I found to be very challenging and difficult in nursing school. So we hope we can kind of break it down, make it a little easier for you guys today. And we're glad to have y'all here. I'm going to hop into the chat myself so I can see what you guys are answering. And again, be sure you guys are sharing this session to all our viewers on TikTok. The more the merrier. We want to reach as many of y'all as possible. All right, let's see how we're doing. I'm getting the chat pulled up here so I can see how y'all are answering. Good work, awesome. All right, so good to see so many of you guys here today. I'm seeing a lot of option 1s, so that's great. Good work, you guys. All right. Well, I'm going to go ahead and pull up the answer and we'll kind of walk through it a little bit. So our correct answer on this one is going to be option 1, atrial fibrillation. So we're going to kind of just walk through what we're seeing on the strip here and what happens with atrial fibrillation so we know how to identify it moving forward. Okay, so again, what we saw here is AFib, atrial fibrillation or AFib. So what we can see here in between those tall QRS complexes are our P waves. And what we're seeing is fibrillation, or kind of like a vibrating of our atrium. So we're not seeing a succinct effort by our heart. So the atrium are acting like a little bit glitchy. Our signals aren't coordinated and they're weak in our atrium. But big picture, essentially what's happening is our atrium are not fully contracting. So that means our blood is going to kind of swirl around in our atrium. We know blood goes from our atrium down to our ventricles. If we have that swirling blood in our atrium, we're not going to be getting as much blood down into our ventricles and as much blood out into our circulation. So also, like when our atrium are kind of quivering and they're not coordinated in the squeeze to move blood down, when that blood is swirling, it's going to pool and we're going to have a high likelihood of thrombus formation, especially in our atrium. There's like a little kind of like peninsula, or we call it an appendage in our atrium, and that's a really big place where blood can pool, where that thrombus formation can happen. And if that thrombus embolizes or kind of goes from being stationary to on the move, our clients with AFib are at a high risk of stroke. So that next place that blood is going to go is going to be up into our brain. We can have a stroke. So that's one of the biggest risk factors with AFib, something we always want to monitor our clients for to ensure that their AFib isn't causing complications like that. But again, something to note. So again, on this ECG, we're seeing an irregular rhythm. So those tall QRS complexes, those represent the electrical activity happening in our ventricles. So our ventricles are larger, they're going to require more electricity to contract, so that's why you're seeing those kind of higher peaks. What we see in our P waves, that's the electrical activity of our atrium. Our atrium are smaller and are going to require less electricity to contract. So you can kind of see what we're seeing. But What we're seeing in our atrium is those fibrillatory waves. What we're seeing in our ventricles is an irregular rhythm. So really no rhyme or reason to the cadence of that ventricle squeeze. They're getting a mixed signal from the atrium, so they're not coordinated in their effort to push blood out to the body. Again, irregular is really the key term here for atrial fibrillation. We see disorganized atrial activity. We see our ventricles still firing, but it's not organized. Good work. I hope that was helpful. All right, question 2, moving right along. The nurse is caring for a client who is short of breath and is experiencing the cardiac rhythm in the ECG strip shown below. Which of the following actions should the nurse take? Option 1, administer an IV fluid bolus. Option 2, prepare the client for synchronized cardioversion. Option 3, instruct the client to bear down. Option 4, prepare to administer IV push atropine. All right, 30 seconds on the clock. Go ahead and drop those answers in the chat. And I'm going to give you guys a hint on this. So sometimes you're going to see 10-second ECG strips. Sometimes you're going to see 6-second ECG strips. But what you're seeing here in this strip is a 10-second strip. The heart rate is going to be 54. So we're taking what we see here, we're counting those QRS complexes. We see 9 here. It's a 10-second strip, so we're going to multiply it by 6 to represent 60 seconds in a minute. So 9 times 6 is 54, so 54 beats per minute. I know it's probably hard to see since we're on, kind of how we're visualizing all of this for you guys. So I'm going to give you just a little bit of extra information to help you on this. But again, this is a 10-second strip with 9 QRS complexes, so 9 times 6 is 54. So that's our heart rate. I hope that's helping, or that's helpful. All right. Good work, you guys. I'm seeing a lot of option 4, some option 3s. Let's see. Good work, you guys. All right. Awesome. And again, if you guys are just joining, we're covering ECG strips. We'll have this available on demand when we're done, so you can go back and take your time, go through these and practice more. Or if you missed any questions, you can go back and see the questions you missed. All right. So our correct answer on this one is going to be option 4, prepare to administer IV push atropine. So essentially the rhythm that we're seeing here is bradycardia. So bradycardia is largely going to look like normal sinus rhythm, but it's just slower. So in sinus bradycardia, essentially what's happening, our SA node, which is what really initiates the electrical activity of our heart, it's going to be firing slower than 60 beats per minute. We can tell this again if we count those R's, which are those tall peaks. So on the 10-second strip, we have 9 R's. We're going to multiply that by 6, which is a 54. So we have bradycardia here. But again, what we're seeing here, all the essential elements of like normal sinus rhythm are here. So we have a P wave before each QRS complex. So again, that P wave and that PR interval represents that electricity and the time for our atrium to contract. That QRS complex represents the electricity and the time for our ventricles to contract. Our ventricles are bigger, they're going to require more electricity. Our atrium are smaller, they require less electricity. So that's that visual representation of what you're seeing. But again, what we see on here, our PR interval is less than those 5 small ticks or 5 small squares. Our QRS complex is 3 or less squares, which is appropriate. So everything is working correctly. Signals are, making their way around the heart, but it's just beating slowly. So a lot of times what we're going to do for treatment, first of all, we would see if they are symptomatic or not. So this client is symptomatic. They're short of breath. We see that in the question. So we know that this is something we need to intervene on. We would likely then see if there's any medications that are maybe causing this bradycardia. So if it's like something like a beta blocker that's dropped their heart rate too much, we would discontinue that medication. Next, we would give a medication, something like atropine. Atropine is going to increase our heart rate. Someone earlier had a great way to remember atropine. It has the word pine in it, like a pine tree. Pine trees kind of look like this, and so that arrow kind of looks like it's pointing up, so it's going to increase our heart rate. After that, we would do transcutaneous pacing, which is like an external pacemaker. And then the ultimate fix for bradycardia for symptomatic clients, after medications fail, would be a pacemaker. So something that it's essentially is internal. It's going to take over that electrical activity that's happening in the SA node, and it's going to kind of outsource it to this to a little machine that's going to initiate that electrical current. So that's kind of where we're at. What we would see, option 4, prepare to administer IV push atropine. That's our correct intervention. What we see in options 1, 2, and 3, those aren't appropriate for what our client is explore fibrillation. Option 4 is sinus bradycardia. All right, I'm seeing a bunch of option 1s come through. Well done, you guys. Good work, good work. That was quick. I'm glad y'all can quickly identify that strip. Good job, you guys. Well done. While you're answering, if you guys are new to UWorld Nursing, if this is your first live, we always encourage y'all to check out uworldnursing.com. You can subscribe to our event calendar and also see other great resources. It's kind of like our entry point into the UWorld Nursing community, but you can see our live schedule, all the content we're going to be covering for the next few weeks, as well as sign up for great features like our question of the week, which really gives you a sample of what UWorld's all about. You get a question to answer in your email, and then it takes you to our explanations so you can see really what makes UWorld stand apart. Our explanations walk through why the right answer is right, why the wrong answers are wrong, maybe what would make those wrong answers right, or where you got distracted, but then also show some of our original illustrations, animations, all that kind of good stuff. So we hope y'all will check it out. All right, good work, you guys. Okay. Our correct answer on this one is going to be option 1, ventricular tachycardia. So what we're seeing here with the VTach, essentially it's going to happen when we have 3 or more PVCs that happen, and they're going to be in a row. So the name is really going to tell us kind of everything we need to know about this. So we have a speed problem, and we have a speed problem in our ventricle. So essentially the ventricle is taking over as the pacemaker of the heart. So what it's going to look like, again, it's in the name, tachycardia. We're going to have a very high heart rate. So we're going to be more than 100 beats per minute. We can see by looking at this, we have those QRS complex, which essentially are kind of like the beats we would count. It's very high, greater than 100. And we're only going to be seeing these QRS complexes, but they're going to be irregular. So our P wave is essentially invisible. That QRS complex has kind of swallowed it up. It's buried it in that QRS complex. So typically our QRS complex is 3 of those small ticks. What we're seeing here is it's much larger, so it's kind of overtaken that atrial activity in the visual representation of what's happening in our heart. But again, we're just seeing ventricular activity, only QRS complexes. But one thing we really need to know about VTach is that it's essential that we treat it. So VTach is the precursor to VFib. VFib can be a fatal dysrhythmia. So we can always remember defib, VFib. So VTach we never want to overlook. We want to make sure we're kind of intervening, stopping that cascade to VFib, and making sure our client stays safe. So we'll talk a little bit later about some of those interventions for VTach, but do know it's something we definitely want to kind of intervene on, make the caregiver or the healthcare provider aware of, and provide medication and support that way. All right, good work, you guys. Moving on, question 4. The nurse is caring for a client who's experiencing the cardiac rhythm in the ECG strip shown below. The nurse should recognize that the client is experiencing option 1, ventricular tachycardia, option 2, ventricular fibrillation, option 3, sinus bradycardia, option 4, atrial fibrillation. I lost myself in 4 option choices. But we're thinking VTach, VFib, bradycardia, or AFib. So drop those answers in the chat. Good work, you guys. And for some of these questions with ECGs, I'm not sure there's always like a ton of strategy that we can, there's strategy, I guess, in terms of understanding the strips, but you can use like a little bit of process of elimination if you're kind of torn between these things. You can kind of go through and see what your options are, and if what you are seeing in that strip is representing maybe like a malfunction, whether it's the ventricles or the atria, or if we have a coordinated rhythm. So like, for example, looking at the strip I would definitely know this is not sinus bradycardia. We know when we see that word sinus, that means we have like all the normal components of a rhythm. We would have a P wave, a PR interval, and a QRS complex. So I definitely don't see any of that here, so we know we can cross that out. We know with AFib, we have disorganized atrial activity, but we still have that ventricular activity showing up. It's not going to be as organized, but it's definitely going to be, we're going to see a differentiation between atrial activity and ventricular activity. So I feel like at this point, it kind of leaves me between options 1 and 2, VTach or VFib. We know ventricular tachycardia, essentially it's just showing that ventricular activity. We're only seeing that just those QRS complexes, but it's typically relatively uniform. So what we're seeing here, I'm like probably going to be thinking this is VFib if I haven't been able to kind of know that right out the gate. So you can use some of that to kind of think about what you're seeing, what you know, if you get a little stumped on any of it. But I hope that helps. All right, okay, let's see. Our correct answer on this one is going to be ventricular fibrillation. So let's talk about, which was option 2. So let's talk about VFib. Okay, so when we have VFib, our ventricles are quivering. They're completely disorganized. So I kind of feel like that's what this strip represents. So when we have normal sinus rhythm, I always think of it kind of like a string, and your string is making a perfect pattern of like P waves, PR intervals, QRS complexes, and it's just doing that over and over, kind of like a nice sewing machine. But then when we get to VFib, it's like someone pulled that string and it just unraveled everything. And that's what's happening with our ventricles. They're unraveling, they're quivering, they're vibrating, they're unorganized. There's just chaos going on in your heart. So when we have that quivering ventricle and we're not getting that big squeeze of blood to the rest of our body, our cardiac output is going to be low. So we're not going to be perfusing our vital organs the way we should. So that's why VFib is life-threatening. We're not getting blood to our brain like we should, to our lungs, all our vital organs. So they're not going to be getting perfused because, again, remember, our ventricles is what squeezes blood out into the rest of our body. So when we look at this strip, we're, again, seeing chaos. There's no P wave. The QRS interval's not really measurable. We're just seeing the heart kind of unravel. So what we're going to do in VFib, if our client is pulseless, we're going to start CPR. We're also going to defibrillate the client. We want to see if we can restart the electricity of the heart. We can also give medications like epinephrine or amiodarone, some different antidysrhythmics. And then we're going to need to give our client oxygen because, again, we know our body's not being perfused with that oxygen-rich blood. It's just kind of, there's not enough activity happening in the heart to perfuse that body. So we're going to support our client with oxygen and maybe with an airway as well. So you guys did great on that one, but remember, DFib, VFib, this is the life-threatening dysrhythmia. Our heart is not squeezing appropriately. We're not perfusing our body. We have a lot of intervention to do when we see this. All right, question 5. The nurse is caring for a client who is experiencing the cardiac rhythm in the ECG strip shown below. The nurse should recognize the client is experiencing option 1, atrial fibrillation, option 2, sinus bradycardia, option 3, ventricular fibrillation, option 4, ventricular tachycardia. All right, let us know what you guys think. Good answers, good work. One of our favorite questions to ask is if you guys have taken your NCLEX, if you're getting ready to take it, if you found out you passed. We love to celebrate you guys. Wish you good luck no matter where you are in your NCLEX journey, but we do all of this for you. We want you guys to be successful in nursing school and on your tests, so we love it when you guys come back and let us know how everything went, and if UWorld was part of your kind of NCLEX prep tool belt, we'd love to know that we made a difference for you guys. So let us know in the chat. Again, we love to celebrate you guys or wish you good luck. And I know we're kind of in the thick of like the end of nursing school. Maybe you guys are really starting to kind of like buckle down on your NCLEX prep if you're testing in the summer. So be sure and check out uworldnursing.com. You can see all of our different subscriptions, the time length on them, all that good stuff. All right, good job. Oh, good luck to Jazz, who's taking yours on Friday. You're going to do great. Good luck, good luck. Awesome. And someone's asking on here how to count beats per minute. I'm just going to tell you guys, this is a 10-second strip. We have 9 QRS complexes. Those QRS complexes represent the beats, essentially. So we are going to take 9 times 6, and this person has a heart rate of 54. So that would be how you do it. but sometimes you'll see 6-second strips, but just know this is a 10-second strip. Our heart rate is 54. All right, and we can also take some of those strategies again, seeing we have pretty organized rhythms, so I feel like I can probably take out options 3 and 4. I see a P wave, which means we have a coordinated effort with our atrium, so I'm not worried about atrial fibrillation, so that's essentially going to lead us to option 2, which is sinus bradycardia. We've kind of talked about this already. All the components of normal sinus rhythm are there. We have a P wave for every QRS complex, so an electrical impulse in our atrium that travels down to our ventricles. We have a coordinated effort. Everything is measuring appropriately. Our PR interval is appropriate. Our QRS interval is appropriate. So 5 boxes for the PR interval, 3 boxes for the QRS interval. Everything is working in order. There's no miscommunication. All that's happening is our heart rate is slow. So that signal from our SA node is maybe having some trouble, having some difficulty, but it's still working correctly in terms of how electricity is coordinating through the heart. It's just going a little bit slower. So our interventions, again, we would discontinue any medications that might be lowering our heart rate, like a beta blocker. We might give medications like atropine to increase our heart rate, especially if our client's symptomatic. We can also do transcutaneous pacing, which is an external pacemaker, and then eventually an internal pacemaker, which is going to take over that electrical activity that happens with our SA node. It's going to be the kind of starting point for electricity in our heart. But you guys did great on that one. Again, this was sinus bradycardia. Well done, you guys. All right. Question 6, moving right along. The nurse is caring for a client who's experiencing the cardiac rhythm in the ECG strip shown below. Which of the following medications should the nurse expect to be prescribed to the client? Option 1, epinephrine. Option 2, atropine. Option 3, rivaroxaban. Option 4, lisinopril. Let us know what you guys think. This is a good question too. You can kind of go through, if you don't know what the strip is, that's always a good place to start. So this is kind of like a two-parter. You have to know what you're seeing and then know what the risks are associated with that dysrhythmia. So you can kind of tell epinephrine is typically a medication we're going to give in those life-threatening situations. So if you can apply that to this strip, we still are seeing a lot of activity in our atrium interventricles. So maybe we can rule out option 1 because we know we're not really in a life-threatening place right now. Atropine, we know, is going to increase our heart rate. So we can see that we've got a pretty solid heart rate here if you count those QRS intervals. But again, you think about it the way you want to. We know rivaroxaban is an anticoagulant. If this strip is showing us we maybe have a risk for thrombus, that would be a good answer. And then option 4, lisinopril, this is going to lower our cholesterol. I feel like this is probably in there as a distractor. All right, let's see what y'all think. I see a lot of option 3, so good job, you guys. All right, so exactly, our correct answer is going to be option 3. So what we're seeing again is AFib. We've talked about this a little bit. We're seeing that fibrillatory or that kind of quivering electrical activity happening in our atria. That's going to cause that blood to pool and to swirl, and that's going to increase our risk of thrombus formation, especially in the little kind of appendage that's in our atrium, like a little peninsula where blood kind of swirls and pools. If our thrombus goes from being stationary to on the move or embolizes, we're at a high risk for a stroke if we have AFib. So that's the first place that thrombus is going to move to, is our brain. So we want all clients that have AFib, we want to encourage them to be on an anticoagulant. We want to make that blood as kind of liquid as possible to help prevent that thrombus formation. So again, we kind of walked through these, but what we see in options 1, 2, and 4, those aren't appropriate for AFib. We want to make sure we're preventing thrombus formation. That's why we do anticoagulants for these clients. Good job, you guys. Prevent that risk of stroke. Okay, question 7. The nurse is caring for a client who is experiencing the cardiac rhythm in the ECG strip shown below. The nurse should recognize that the client is experiencing option 1, atrial flutter. Option 2, atrial fibrillation. Option 3, premature atrial contractions. Option 4, premature ventricular contractions. All right, drop those answers in the chat. Good work, you guys. And again, thanks to everyone that shared this session. We hope y'all will Oh, I saw someone just passed your NCLEX in 85 questions. Congratulations. I missed your name. It was on TikTok, but it flew by too fast. But congratulations. But again, if you guys are just joining, we're covering ECG questions. So all of those kind of tricky ECG strips, we're walking through, hopefully breaking them down a little bit for you guys, but we'll have this available on demand when we're done, so you can go back and practice if you're just now hopping on. We'll be sure you can slow it down, look at everything, take your time answering these questions. We also have a Live and Learn lecture on ECGs as well, so you can always search that. It's helpful to search them typically on YouTube, so feel free to check that out as well. All right, so let's see. I'm seeing a lot of option 4. That is very good. Y'all are doing great. Good job, you guys. Again, we can kind of rule out some of these options. We know we've seen atrial fibrillation a couple times now. We can see coordinated atrial activity. We're seeing that P wave, that PR interval before our QRS complexes. It seems like we might be having a little bit of an issue with our ventricles based on the width of the QRS complex and kind of how it has a little bit of disorganization. So I'm thinking this is definitely something ventricular, but we'll see. Good job, you guys. All right, so you got it. It was option 4. We're seeing premature ventricular contractions. So what we see with PVCs, we're going to see a variable heart rate. So the R to R interval is not going to be consistent. And again, those Rs are the kind of peak of our QRS complex. We're also going to have an irregular rhythm, which just means that our transition from atrial activity on the ECG to ventricular electrical activity, it's not going to be smooth. So that's exactly what we're seeing here. And then some of that irregular rhythm, it's going to swallow up that P wave again into the QRS. So we're going to be out of sync, and we're going to have kind of like a jolt of energy happening in our ventricle. So our P wave is going to be hidden whenever we see these PVCs happening, and we're not going to have a measurable PR interval because of that. The QRS interval is going to be wide and distorted. Typically, that QRS interval is supposed to be 3 ticks. So QRS has 3 letters, and it should be the width of 3 of the tick marks on the ECG strip. A note about PVCs, so 1 PVC is not a big deal, but we need to monitor if our client is getting more than 1 PVC, if they're happening more frequently, if we have 3 or more. PVCs are the kind of precursor to VTach. VTach we know is the precursor to VFib. VFib we know is a lethal dysrhythmia, so we need to intervene. So again, anytime we're kind of messing with the heart, if we do any type of intervention, maybe like a stent placement or anything that we're going and kind of aggravating or agitating the heart, we would expect to see a PVC. But again, it's more about monitoring the frequency of those PVCs and how consecutive they are. So if we're having 3 or more PVCs, that's considered VTach. We want to stop that cascade to VFib. So we really want to be sure we're intervening with some of those interventions, those medications. So good work on that one. All right, last question, question 8. The nurse is caring for a hemodynamically stable client who is experiencing the cardiac rhythm in the ECG strip shown below. Which of the following actions should the nurse take? Option 1, prepare to administer amiodarone. Option 2, prepare the client for immediate defibrillation. Option 3, continue to monitor the client. Option 4, request a prescription for digoxin. All right. Drop those answers in the chat. Good work, you guys. Last question, y'all are doing great. We're so glad to have had y'all here today. We always encourage y'all to follow us on your favorite channel. We're at uworldnursing on all of our platforms. And again, check us out at uworldnursing.com. Our event calendar is up there. You can see all the content we're going to be covering on our lives. And for sure, come back tomorrow. We're going to be covering oncology questions. So talking through some of those oncological emergencies, safety for clients, safety for nurses, and some radiation questions as well. So be sure and come back, same time, same place tomorrow. All right, you guys. All right. So our correct answer on this one is going to be option 1, prepare to administer amiodarone. So again, the rhythm that we're seeing in this strip is VTach. We see these important words though in the stem. The client is hemodynamically stable. So hemodynamically stable would mean our blood pressure is maintaining, our heart rate is maintaining. We're not seeing any changes that would indicate poor cardiac output, like changes in our LOC or mental status changes, urination, anything that indicates perfusion to our vital organs. So far we are okay. So since the client is stable, that's going to indicate that we're going to treat them with medication like amiodarone. Alternatively, we could also do cardioversion, but we're seeing as our option here amiodarone. Amiodarone is an antidysrhythmic medication. So we're going to bolus that to the client and then maintain them on an amiodarone drip until we figure out the best next step for them. What we see in option 2, we're not going to defibrillate this client. Again, they're stable, they have a pulse, we're okay. We don't need to defibrillate them. We would defibrillate when we got to VFib, so defib, VFib. We're not going to just monitor this client. Same idea. We don't, VTach is a precursor to VFib. We want to intervene so we're stopping that cascade to this lethal dysrhythmia. And then option 4, requested prescription for digoxin. Digitoxicity or high levels of digoxin in our bloodstream can actually cause VTach. So this can be an attributing factor to what we're seeing here on this strip. So definitely we don't want to do that. We don't want to perpetuate the problem or make it worse. So amiodarone is an antidysrhythmic medication. It's going to do what it does to reset the rhythm of the heart. This is our correct answer. So y'all did really great on that one. Again, thank y'all so much for being here. We encourage y'all to check us out at uworldnursing.com. Again, this will be available on demand, so come back and check it out on your favorite channel. Come back tomorrow at 3 p.m. Central Time. We'll be covering oncology questions. We appreciate y'all being here, and we'll see you next time.